specialist to give us an overview of the clinical features, diagnosis, and management of COVID in children. Then we'll have Dr. Satish, who's a pediatric rheumatologist, to talk about multisystem inflammatory syndrome in children associated with COVID. And then finally, we'll end with Dr. Ebor Jacob, who's a pediatric intensivist, who will talk about the critical care management and our experience in the pediatric ICU in relation to COVID. So without much more, I invite Dr. Valsan Verghese to start to give his talk.
I'm actually going to give an overview about the clinical features, diagnosis, and management of COVID in children. I'll be followed by Dr. Satish and Dr. Ebor. So just to start, the person who first taught me how to present always said you should have an introductory slide. So that's my introductory slide about what is SARS-CoV-2. It's a coronavirus. It's a beta coronavirus, and it's one of the three that cause severe infections after the original SARS and MERS. Very interestingly, disease severity is less in children. Even the incidence is less, because if you were to look at the numbers from China in the early part of the epidemic, children made up 17% of the population, but only 2% of the cases. Very similar figures from the US. 22% of the population, 1.7% of the cases. And when you look at deaths, just 0.2% in both China and the US, compared to an overall case fatality rate of 2.3 and 5.4%. European figures, multicentric from hospitals, showed a mortality rate of 0.69%. If you were to look at the grades of severity, what's interesting is to note that children have many more asymptomatic infections, about 13% compared to just 1% in a whole population. Mild and moderate together make up 80%. When it comes to severe infections, the whole picture changes. Adults have 13.8% severe, 4.7 critical. Children only have 2.5 and 0.4. And among that, the younger children are the ones which are most likely to be affected. So just to talk about why this happens, I'm going to just talk a bit about pathogenesis. So something we all know after all these lectures, SARS-CoV-2 binds to the ACE2 receptor, and the serine protease TMPRSS2 cleaves the S protein, binds it, allowing the virus to fuse, endocytose, and replicate. So what is actually happening is as soon as the viral entry occurs, there is cytokine release. This is actually followed by extravasation or infiltration from the capillaries of macrophages and lymphocytes into the alveolar lumen, and then pneumocyte proliferation and necrosis and release of more virions. Severe cases progress to interstitial edema, and that is because of increased vascular permeability. There is also a fibrinous exudate that forms, and this lines the alveolar walls in the lung, forming something like a hyaline membrane. In addition, there is microthrombus formation, and due to activation of the coagulation cascade, and this is actually what causes alveolar capillary diffusion abnormalities and impaired oxygenation. Now, why is this less severe in children? Firstly, there is decreased epithelial expression of ACE2 and TMPRSS22 in children compared to adults, and compared to adults who have increased pro-inflammatory cytokines, children have increased immunomodulatory cytokines such as IL-10. So in addition, they have a more effective cytotoxic CD8 cell activation, a better humoral antibody response, and the concept of trained immunity, which is an permanently active innate immune memory because of frequent viral infections and vaccination. So this is actually reflected in the differences in clinical manifestations. When you look at adults, 70 to 80% present with fever and cough, whereas in children that number's just over 50%. Again, predominant symptoms such as myalgia and headache, much more common in adults. If you look at labs, what you find is that only a minority of children have the laboratory findings that you expect to see in adults. Lymphopenia is seen in less than a half. Procal is increased in less than a half. All the rest is hovering around 15 to 20%. So one systematic review looking to see whether you could predict severity based on the labs. This is in the early part of the illness, before inflammatory syndrome was described, said they could not actually make out just based on the laboratory investigations. If you were to look at X-rays and radiology, CT is being described first because for some reason in China, they found it more easy to do CTs than X-rays. And these are the classic described abnormalities, ground glass opacities. On the left of your screen, the first picture, little arrow, you can see the ground glass opacity. Towards the middle, you can see the halo and the reverse halo. The reverse halo is actually a ring of consolidation surrounding the area of consolidation. And within the consolidation, that's your third picture, you can actually see what is called septations within consolidation. And this is the crazy pavement appearance. This progresses on to white lung. Interestingly enough, 33 to nearly over 50% of children with mild infections have normal CTs, unlike adults who tend to have CT findings, even with very mild infections. X-rays are even more variable. So initially can be normal, followed by perihilar shadows, diffuse interstitial infiltrates, lobar or multilobar consolidation, ARDS. And for those of you who are interested, I would actually recommend this British Society of Thoracic Imaging guidelines on how to interpret X-rays. However, and that's the last picture on your right is actually bilateral peripheral airspace disease. However, it's predominantly based on adult findings, and it's actually not been validated. So children can have X-ray pictures that resemble any sort of viral pneumonia. Now, talking about diagnosis, I'll just ask you to look at this blue line over here, which is actually the nasopharyngeal PCRs. These are positive in the first week of the illness, peak within the first week, and then the mean duration is about 2 weeks. Half of children become negative by 15 days. Although PCR positivity can continue for 37 days, there is no virus isolated after day 10. So that's probably inactive, viral remnants. Stool PCRs, which is the yellow line, actually persists for a very long time. Even then, no virus has been isolated from these stool PCR positive samples. Immunoglobulins, IgG and IgM, these are the dotted lines over here. They start towards the end of the first week and then go up for about 14 days. IgM lasts for about 8 weeks. IgG, we are still finding out how long it lasts. We know that it tends to persist between 3 to 5 weeks. I mean, you will know more later as more and more tests are being done. So just to summarize, children seem to have a different clinical course. They have the acute phase. They tend not to have the subacute phase, which is actually the hyperinflammatory phase, and the late phase of fibrosis. Compared to adults, and you can see that adults tend to take a long time to recover. Children recover faster. Older adults tend to have more severe issues. So on the whole, things were looking good till the first case of multisystem inflammatory syndrome was reported in April. This is by an Indian American hospital pediatrician in the US. She described a 6-month-old, 2 days of illness, rash, conjunctivitis, strawberry tongue, edema and erythema of hands and feet, a complete Kawasaki. PCR was positive, was treated with IVIG and aspirin, and echoes were normal. This was followed from a spate of reports initially from Italy and France, and they noticed a 30-fold increase in Kawasaki disease. And then when the US started reporting from June to July, they saw that 10% of all pediatric COVID was inflammatory syndrome. So what is interesting is it occurs 2 to 6 weeks after SARS-CoV-2. Median period is about 42 days, up to 6 weeks. Because it tend to occur late, it's most commonly antibody positive and PCR negative, but in the acute to subacute phase, they can still be PCR positive in about 25 to 40%. Now, I'm not going to spend a lot of time on this picture because Dr. Satish is going to explain the pathogenesis. I just brought this up to show you that a lot of these children actually have asymptomatic or mild infection. They skip the pulmonary phase and go straight into the multisystem inflammatory syndrome, and this is reflected when you look at the differences in clinical manifestations. So respiratory symptoms are much less common in this group of patients. They tend to have a lot of GI manifestations. In addition, they have signs of which would fit in with the Kawasaki, like conjunctivitis, rash, lips, oral changes between 15 to 40%. The incidence of Kawasaki itself within this group is 20 to 40%, and shock and acute renal failure are much more common with this syndrome. And again, we saw the labs were not very elevated. In this situation in MISC, you actually have almost anywhere from 70 to 100% increased acute phase reactants, D-dimers, and most interestingly, myocardial dysfunction, pericarditis, and coronary artery changes. So we are actually going to talk about management. The case definition is basically similar to the influenza-like illness, any acute respiratory illness with a history of travel or in contact, of course, and any severe acute respiratory illness or SARI requiring hospitalization. So if you were to grade disease severity, mild in disease is basically your upper respiratory infection. Severe or moderate disease is your non-severe pneumonia, which is fast breathing with a normal oxygen saturation. Severe disease is severe pneumonia, which is fast breathing plus cyanosis, respiratory distress, or any danger sign. Critical disease, and Dr. Ebor is going to be talking about it, includes worsening oxygenation, ARDS, sepsis, septic shock. Multisystem inflammatory syndrome is not defined as critical disease, but in our definition here at CMC, we are putting it as part of critical disease. And Dr. Satish will talk about it. The definition we are using is the WHO definition. The last little paragraph is what we have added from the RCPCH and the CDC guidelines. So as far as management goes by disease severity, mild disease is like any upper respiratory infection. You treat symptomatically, paracetamol for fever, no need for any antibiotics, monitor and home isolation. Moderate disease, that is non-severe pneumonia, we admit all these children, we send counts, blood culture, we do a chest x-ray, we do an influenza swab, and normally start an empiric antibiotic, especially for children under the age of 5. In an influenza season, you could consider giving oseltamivir, but oseltamivir itself does not affect or change the course of the illness. Now, for severe illness, this is the situation where we need to give oxygen. We go up on the antibiotics, and in this situation, we start DEXA and prophylactic dose anticoagulation if the D-dimer is elevated and there is no contraindication for starting anticoagulation. The reason for giving DEXA actually comes from the recovery trial, which shows that 35% of deaths were reduced in those mechanically ventilated and 20% of deaths in those needing oxygen. No benefit in those on oxygen, so we try not to give steroids unless the child is in having a severe pneumonia. Now, Dr. Ebor is going to talk about these, so I just left it here because I know you are getting the PDF slides, so just to show you our protocol for critical disease, and Dr. Satish will be talking about multisystem inflammatory syndrome, about the role of IVIG, aspirin, methylprednisolone, and tocilizumab. So I just want to end with this very cheerful slide. Although it looks very scary, most of the series have shown almost uniformly good outcomes with IVIG and aspirin. The time it takes from treatment to remission of fever is 2 to 5 days. Inflammatory and cardiac markers resolved by 2 weeks. And in the studies where they have followed up with cardiac imaging, most children have recovered despite the myocardial dysfunction and coronary disorders, and mild cardiac dysfunction is seen in a minority. Thank you, and over to Dr. Satish.
Good evening, friends. I'm just going to talk to you about COVID-19 related hyperinflammatory syndrome in children. So this is a report from ICMR yesterday. What they said was India has not reported any case of Kawasaki disease in children with COVID-19. This is from our ICMR president yesterday about this. So what I am going to talk is about the nomenclature, about the clinical features, diagnosis, and what is the treatment guidelines for treating this condition. Okay, you all got confused. Somebody said PIMS-TS, somebody said MIS-C. There are different nomenclature, multiple case definitions, like multisystem inflammatory syndrome in children, pediatric hyperinflammatory syndrome, or pediatric inflammatory shock. Somebody said pediatric multisystem inflammatory syndrome. Somebody said PIMS-TS associated with SARS-CoV-2. So why there are so different nomenclatures? Okay, so what we are going to talk, what I'm going to talk is about the clinical spectrum. Valsan has already talked about the clinical spectrum, about the mild and severe cases. What I am going to talk to you about this COVID-19 associated MIS-C, which can present in 3 different ways. One is they can present with persistent fever along with headache and fatigue, typically like a viral fever, but they have raised inflammatory markers, very high ESR, high CRP, but there is no signs of severe multisystem involvement. Second group is Kawasaki-like illness. So they can present like complete Kawasaki disease or incomplete Kawasaki disease. Again, they don't develop shock or other multi-organ involvement. The last group is a severe MIS-C, where they have very high inflammatory markers and they have severe multisystem involvement, especially the cardiac involvement. So when you look into the definitions, there are 3 main definitions. Valsan has already spoken about this. So mainly from UK, they call them as PIMS-TS. CDC from the US, they call them MIS-C. WHO has adopted these 2 and called them as MIS-C. So if all of them tell the same thing, which little bit of different. In UK, they said all children, age was not different. Has to be there, and clinical symptoms wise, they should have single or multi-organ dysfunction as additional features. So all of them said the same thing. WHO is little more very and easily understandable, because they should have either some signs of Kawasaki disease, or they should have shock, cardiac involvement, coagulopathy, or GI symptoms. And all of them said they should have signs of inflammation, either by raised ESR, CRP, fibrinogen, procalcitonin, D-dimer, ferritin, LDH, IL-6. So all comes under the inflammatory markers. And what is the link towards SARS-CoV-2? Either RT-PCR is positive or it can be negative. Antibodies can be positive, or sometimes there is just exposure within prior 4 weeks is enough. We should not need to have, sometimes you can have antibody negative, you can have PCR negative. So especially when we are living now with the community transmission, any child who presents to your casualty or OPD with this symptom complex of fever with more than 2 organs involved, you should suspect whether the child has got MIS-C. And again, remember, all the other infections has to be excluded. So what are this? These are the 3 main case series or cases which is reported in literature. The first one came from France. They reported 16 children with pediatric multisystem inflammatory syndrome. They called them associate mimicking like Kawasaki disease. They said it could be Kawa COVID-19. That's the first publication, which is published in June. Then following this is from the UK. They also published almost 58 children with similar symptoms. They call them as MIS-C. And late in July, from US, 186 children were published with the similar symptoms. So when you put together all the clinical features, so most of them had fever. All of them had fever. Predominant symptoms are gastrointestinal symptoms, abdominal pain, vomiting, diarrhea. Then they have Kawasaki-like illness, especially rash, conjunctivitis, and mucosal involvement. And they can have shock. Sometimes they can have complete Kawasaki disease criteria. They can have myocardial dysfunction. And they also can rarely reported to have seizures, coma, or meningoencephalitis. So any organ can be involved, but very common are these 3. So to summarize, when you suspect MIS-C, so anybody who comes with fever in this time with evidence of abdominal symptoms, Kawasaki-like illness, myocarditis, shock, or they can present with acute renal failure also. You should suspect. So if you look into the clinical practice of any pediatrician, any child who comes to the OPD with these symptoms, you should suspect MIS-C. So what is the difference between the classical pre-pandemic KD and PIMS-TS associated Kawasaki disease? If you look into that, the age of presentation, we always tell Kawasaki disease is a disease of small child. But here in MIS-C, it is up to 7 to 9 years. And you can see there are a lot of gastrointestinal symptoms, cardiac dysfunction, coagulopathy, shock. And you can see here, CRP is markedly elevated. So somebody comes with fever with very high CRP, you should suspect MIS-C in this condition. And they also have coronary abnormalities are very less in Kawasaki-like illness associated with MIS-C, where in pre-pandemic KD, where you have a lot of coronary artery abnormalities. And remember, thrombocytopenia, again, especially in Kawasaki disease, we say that thrombocytosis will be there. Now here, but you'll have thrombocytopenia also can be seen. So what is the pathogenesis? This is from the NEJM paper you see here. So these are the yellow one is the percentage of the people, especially the adults who are positive with SARS-CoV-2. And the red bars are the number of MIS-C cases. What you see it here is, after the peak, which almost happened in the April first week, you see a lot of MIS cases 2 to 4 weeks after the month after the peak curve. So especially if you live in India, now the peak is reached and we are now started to seeing number of cases are getting decreased in the adults. This is the time we should be more vigilant to pick up this case of MIS-C. And again, I told you majority of the test for SARS-CoV virus, but positive for the antibody. If you have a test to do the antibody, you can do it. But even if the antibody comes negative, if you have the clinical features suspicion of MIS-C, you should treat like MIS-C. You cannot say antibody negative and RT-PCR negative. So what they find out is it is more of acquired immunity than the direct viral injury. And similarly in the dengue fever, here also antibody dependent enhancement of the symptoms are there. So this is one of the proposed mechanism. As a pediatrician, we all know about acute rheumatic fever. So this is similar to that. So here what you see this in SARS-CoV-2 host-host interaction, we have multiple exposures of COVID-19 parents to the children. And then if you are genetically predisposed and like a molecular mimicry, what you see in acute rheumatic fever, uncontrolled T-cell mediated immune response leading to inflammation, which can cause all the symptoms of PIMS-TS. So this is one of the proposed mechanism, superantigenic stimulation leading to cytokine storm. This picture Valsan has shown already. So what you all know is this a stage 1, where is the early infection. In children, the pulmonary infection phase is usually not seen. So what they do is all these viruses stimulate the macrophages and they cause this hyperinflammation phase, which is a delayed phase where the T cells are stimulated, then the B cells are stimulated, plasma cells produce antibodies, which can again cause hyperimmune response, and a lot of pro-inflammatory cytokines are released, leading to all the features of multisystem inflammatory syndrome in children. They can have CNS manifestation, they can have cardiac manifestation, shock, kidney injury, and abdominal symptoms. So when you do the lab tests, so what will you see? Usually we see lymphocytopenia, and you see these inflammatory markers, especially the CRP, 90 to 100%. CRP is one of the very, very important. It is a surrogate marker for IL-6. So if you cannot do IL-6, don't worry. CRP itself is a surrogate marker for IL-6. And if they have present with cardiac involvement, they will have elevated cardiac enzymes. And again, with cardiogenic shock, you will see have depressed LV function, coronary artery aneurysm, dilatations can be also seen. So when will you suspect MIS-C in children? So clinically, when they come with fever, when they have come with shock, when they come with gastrointestinal symptoms, they come with the rash, neurological symptoms, with hepatosplenomegaly or lymphadenopathy. So whenever you write the diagnosis of sepsis, always think, especially in this condition, in this era, you should suspect MIS-C. So I'm going to show you some rashes. This is another 5 years old child, one of our patients who presented with fever and shock, treated and went back to the COVID ward. There, 5th day of illness, she developed Kawasaki-like. You can see this eye congestion, rash, peripheral edema. This type of children unusual to have a lymphadenopathy. And this is the one child in the ward currently. This boy again presented with the fever, diarrhea, and shock. You can see the typical eye congestion. You can see this rash on the body. And this is another one child who was admitted last week, went home this week, again with PIMS TS or MESC. You can see the rash on the hand. So when will you suspect? When you have the laboratory, I told you CRP, especially more than 50, very high procalcitonin, ferritin, dearranged liver enzymes, triglycerides are high, D-dimers are high, you suspect. Again, lymphopenia, thrombocytopenia, decreased ESR and fibrinogen, they are going for HLH like picture, hypoalbuminemia, hyponatremia, you should suspect MESC and acute kidney injury. GA manifestation, they all can present GA manifestation. So any older child coming with GA manifestation, please suspect MESC. They can mimic like appendicitis. There are also reports of pancreatitis. We have seen one child with pancreatitis due to COVID. Okay, if needed, you have to do ultrasound or CT to exclude the other causes. Cardiovascular, febrile cardiogenic shock. They may not need the criteria for Kawasaki disease. They will have shock with low BP. They'll have left ventricular ejection fraction is very low. Coronary aneurysms are little less compared to the typical pre-COVID Kawasaki disease. So they also can have neurological features, and they also can present with cytokine storm or like macrophage activation syndrome or HLH in small group of patients can go for that also. So management depends on the severity of the illness. So what is the treatment recommendation? We have two guidelines, one from UK and one from US. So the first one is from the Lancet in September 2020. This is from the UK, and from the US, we have the ACR clinical guidelines for multisystem inflammatory syndrome treatment in July. So I'm just comparing both, and I just simplified. What they said is UK, they said positive RT-PCR, you can consider remdesivir if you, but remember that most of the time MIS-C is a hyperinflammatory syndrome post-COVID disease. So most of the time we will not use remdesivir. They all said intravenous antibiotics in all patients, especially when they present with toxic shock syndrome phenotype, antibiotics plus clindamycin. Remember that infection screen need not to be negative to start steroids. Don't wait for the culture to come. Culture negative, then I will start steroids. Then the golden period is gone. Here ACR says empirical antibiotics as per the local protocols. And what is about the immunomodulation? So UK and ACR almost said the same thing. So what they said in UK was you have to give IVIG when they present like Kawasaki-like illness. You have to give the same IVIG 2 grams per kilogram. If there is no response, you can consider second dose of IVIG or methylprednisolone in children, especially less than 1 year, or if they have coronary artery changes, you give injection methylprednisolone. This is the first line. So you have to give IVIG plus methylprednisolone. Second line, again methylprednisolone. If there is no improvement, you go to a third line. If they present with KD phenotype with coronary artery aneurysm, you give infliximab. If there is only cardiogenic shock, myocarditis, you give tocilizumab. What is ACR says? Again, they gave IVIG plus or minus glucocorticoids and IV methylprednisolone. And the third tier is again tocilizumab, which is IL-6 blocker. Anakinra is IL-1 blocker, which is not available in India. So we have to start on both IVIG and methylprednisolone. These are the guidelines which were given. What about antiplatelets and anticoagulation? Antiplatelets, very simple. You treat like KD. So in KD, what you do, you start on high dose aspirin, which is 30 to 50 milligram per kilogram. Once the fever settles, you make it to low dose aspirin for 6 weeks or till the echo becomes normal. Anticoagulation, they didn't say anything in the UK guidelines, but in US guidelines, they have very specific for anticoagulation. If they have coronary artery aneurysms, the Z score is more than 10. If there is a documented thrombosis, or if the ejection fraction is less than 35%, you have to give anticoagulation. So IVIG, what they say is maximum 70 grams in children. Some report says you can go up to 100 grams per dose. So 2 milligram per kg, maximum 70. This is what we follow. And IV pulse glucocorticoids are used in life-threatening complication when they come as shock, or if the patient requires multiple inotropes or vasopressors, or can be also used upfront if they are unable to afford IVIG. So if they cannot afford IVIG, at least you give steroids in these situations. Anticoagulation, very clear. If the ejection fraction is less than 35, if there is a thrombosis, or if the coronary artery dilatation Z score is more than 10. So this is the diagnostic pathway. So what you do, so does the child have all our following? When will you suspect? So when somebody comes with fever, epidemiological link to SARS-CoV-2, all over our country is now epidemiological link to SARS-CoV-2. And if they have 2 of the clinical features, yes, rash, GI symptoms, edema, oral mucosa, conjunctivitis, lymphadenopathy, or neurological symptoms? If it is yes, you should consider MIS-C and start evaluating for MIS-C. Especially, you should start doing the test like CRP, ferritin, all the tests has to be done. Suppose if they don't have those type of things, you look for the other cause and you continue to do the diagnostic evaluation as per the standard protocol. If they develop any of those things which is suggestive of MIS-C, you should consider MIS-C and you should treat appropriately. So if they have cardiac involvement, cardiac enzymes, troponin, and BNP, all can be done. And if you suspect cytokine storm, then triglycerides, fibrinogen, ferritin, all has to be done. So what is the take-home message? So 3 common phenotypes are there in MIS-C. One is Kawasaki-like presentation. They can come with gastrointestinal presentation or neurological presentations, so OPD. Other differential diagnosis, especially toxic shock, should be ruled out prior to treating MIS-C. And CRP, very high inflammatory marker. You have to consider MIS-C. And first-line treatment is IVIG plus or steroids. Second-line treatment is include tocilizumab, anakinra, and infliximab. Again, we always need a team to manage children with PIMS TS, especially in CMC. We are very lucky because we have a very good pediatric team. We have a very supportive intensive stream. We have a cardiology backup, infectious disease backup, and we have a rheumatologist. So to manage a child with PIMS TS, we need collaboration of all the specialists, especially when the child is sick in the ICU. So I'm going to stop it here. Thank you for patient listening.
Good evening all, and it's my pleasure and privilege to be here in this forum for talking about the COVID infection in children. So now Dr. Valsan and Dr. Satish has covered most of the things which we need to know. And so I will be talking mostly about in ICU management. In that I'll start with our experience, what we have seen in the past 3 or maybe 4 or 5 months. And then what about the essential critical illness management? What are the things which we do for this MIS-C or the PIMS TS, which Dr. Satish has elaborated very well. So as we know, severity profile of COVID-19 is based on this in adult as well as in children also. And see, very less amount of patients need intensive care. And before that, we need some essential care, which may require proper monitoring and some oxygen. So what about in our unpublished data, which we have gathered in the past, starting from April end, for the past 5 months, May, June, July, yes, 5 months. So we have a pediatric HDU, which is part of ICU. We are made into a COVID suspect screen, as well as a part of it is for positive children. So all those who are sick, means needing oxygen, danger signs on shock, will be screened through that. And we got about 366 children. And another about 365, this little approximately, which was screening through the emergency, they went to the wards. So totally we had about 731 children. And among that, we had so far 420 positive. That means about 57% of these children were positive among the screened children. So what about in PICU? Those who are presented with some sickness, some severity or critical illness. So 366, and among that, we had only 47 were positive. So that's what 11% among the sick children were screened in the ICU. We had 1 death so far, and 1 child was discharged against advice. That means the child was referred to for the surgery to another center. So we had about total positive, as I said, 420, and PICU, or that children who required intensive care, were 47, about 11%, and mortality was only 1, that's about 0.2%. This is the month-wise data, and I'm not just elaborating, this is what we screened and those who are positive. And this is among the positive, how many? Both are little between 6 to around 14%, depends on. So the month-wise, if you see, peak was in August, September now is coming down. Coming to the age group, Under 5, about 23 children. And 6 to 9 years, 7 only. And adolescent, about 17 children. Male and female predominance, no predominance, both are equal. And this slide talks about the presentation, the mode of presentation, means whether they were in shock, pneumonia, cardiac, that may be overlapping. So most of the children had shock, that's about 22 of them, that's about 40%. And you can see in pneumonia ARDS, we had only 11, that's 20%, which in adult world, they are saying more of ARDS in our institute. CMC's data also looks like that. They present with the ARDS manifestation, not much of cytokines now. So here we have seen shock followed by some neurological, they come with seizures. GI symptoms, about 7 children, one of them presented with pancreatitis, others all like a diarrheal disease. Coming to the severity of the disease, as it's given in our protocol, which is in our internet published, and it will be given to us. Dr. Valsan talked about this. So based on the WHO, we have divided into moderate, severe, and critical. Moderate, any children who are tachypneic, but this may give you more elaborate about that. Mild disease, they are having some sort of a fast breathing, may require a little bit of oxygen or may not. Then moderate, they are tachypneic and there is no retractions, but they require oxygen. There is no danger signs. Severe disease or severe pneumonia, when there is danger signs, grunting, may require a escalation of respiratory support. Then we have the critical disease, and that includes pneumonia with the ARDS, sepsis, septic shock, and multi-organ dysfunction. So among that, 47 children, we had about 18 children with critical disease, moderate to severe were 19, and MIS-C were 10. This is among those who are PCR positive, okay? The MIS-C 10 is about 21.2%. So severe disease is 5, critical is 18 children among the 47, and MIS-C is 10. This is among those who are PCR positive. And we also looked at the inflammatory markers. We did coagulation parameters and cardiac markers. And inflammatory markers, ferritin was raised in 21. This is about CRP or procalcitonin, abnormal, and D-dimer and PT-PTT. And this is about pro-PNP. They're not doing it much. We do most of the children trop-T. And we have found some of the children who are pro-PNP. We don't do both. Either of them can be done. So comorbidity, yes, we looked at that. About 23 children have comorbidity, prematurity, type 1 DM, primary adrenal insufficiency, malignancy, and congenital heart disease, chronic kidney disease, and one child who had a post-op Kasai. These are the comorbid factors we found in our children. And what about the ICU therapy? So as I told you, the pneumonia ARDS was very less, and we had only 6 children who were ventilated. And most of them require respiratory support as high flow nasal cannula therapy that we all know, which gives you a good flow, washes out the CO2, but may give some PEEP, which can be done in the wards as well. And 22 children required vasoactive agents in the form of adrenaline or NORAD, and they are fluid unresponsive, so we have to start on catecholamines. 18 children required dexamethasone and Lexane, which as per our protocol, which we start for severe to critical, but we are not strictly following the protocols. So case by case, we may be starting. So 18 children received Dexa and either unfractionated heparin or Lexane. IVIG, we received 2 children received because they were, as Satish pointed out, and they presented like rash and Kawasaki-like illness. And the duration mean is about 4 days. And this is the outcome. As I already told, there was 1 death and is about 0.2% mortality. What about comparing to the literature or in North American? This is the morbidity mortality weekly report of the CDC, which says about 33% of children hospitalized admitted to ICU. But in our experience, it's about 11%. And they found more children under 2 and more in the 5 to 17 age group. That in this paper, which is recently published with 585 cases in the Europe, they also found same. So you look at this violent type, this is a similar thing. We also had under 5 children, about 22, and in the adolescent group, about 17. Between the 6 to 10 years, very less patients. I'll skip this. This is about an ICU statistics. For want of time, I'll just go to the management part. This says about, it's a pictorial representation. As you know, mild to moderate respiratory tract symptoms, they can be managed in ward. We did receive some of the moderate children who required some high flow nasal cannula, supportive treatment. And what about antiviral? We have not given anybody and remdesivir or any other antiviral in pediatric ICU. They have been treated with probably antibiotics, and if they require some nebulization, is being given. Even in COVID, yes, we have used, and some respiratory support. And when they are critical, accordingly, whether they are in hypotensive shock, they have been given fluids and inotropes, and even up to ECMO, we have went to support these children. So as I told, respiratory distress pneumonia, ARDS, we didn't see much of the ARDS patients, but as I told, our experience is we stop with high flow. So low flow cannula we have, and the high flow cannula, I'm not fully explaining all this. So this is the respiratory support cascade. We start with low flow, then we can have high flow nasal cannula, non-invasive with mask, that has a good response, and then we go to invasive supports. And prone ventilation also can be done, but our experience in the ARDS due to COVID is very less, but we do have ARDS patients with other illnesses. And so what about steroids? As we told, yes, we do use for any children who present with severe or critical dexamethasone 0.15 milligram per kg, max up to 6 milligram once daily we give for 10 days, or at the time of discharge we stop. And apart from that, other supportive therapy, yes, we do give. And this is, we all know about the recovery trial. I'm not going into this. And what about remdesivir? Even in literature, there is not much for evidence for data for children. And there are some lack of safety as well, because it involves, it is created through hepatic and renal. Any critically ill children who have been affected with this, we have to be careful. And we have never used remdesivir in our children in PICU. Antiplatelet and anticoagulation, this is from the Winsely treatment protocol. See, aspirin, and so when we come to the Winsely, probably I'll talk about that. This is the same child which Dr. Satish mentioned, is about 5-6 years old, who presented with hypotensive shock, probably sepsis, and had a seizure. So we treated like a CNS infection. So initial management of sepsis and shock, we never forget, even in COVID era, that has to be stressed upon. Yes, we know IVIG steroids are important. At the same time, first hour management of sepsis with fluids and antibiotics is a must, because we may not be knowing initially what we are dealing with, and we have to follow that. This talks about the same, and we have to do blood culture, antibiotics, appropriate fluid boluses using isotonic crystalloids. If they are unresponsive, we have to start vasoactive agents. So this child, we sent inflammatory markers, which was high. Ferritin was 1,200. He had some myocardial involvement. Echo showed some ejection fraction of 40-45%. She fit into the critical stage disease. So we started on dexamethasone and as well as heparin. So this is the child who developed rash, as Satish said later, day 4, day 5. So then we had this presentation, fever, the child didn't have respiratory illness, but had shock, myocardial dysfunction, rash, and inflammatory markers were high, and abnormal D-dimer. So what was this? So we gave, as he clearly mentioned about the Winsely and PIMS-TS, we followed the protocol and we gave the IVIG, DEXA, and enoxaparin as well. Child went home well. So this spectrum of the disease, Dr. Satish went on elaborated, and we know initially we don't know what we are dealing with. Probably now we are much clear. It's a single entity with different varied spectrum, but still I feel we know only tip of the iceberg. We need to know a lot about the management as well. This is the WHO protocol, a definition. In all definition, we need to have fever, evidence of increased inflammatory markers, which Dr. Satish said, as he said, CRP will be very high, or a procal will be also higher than what we see normally in inflammatory disease. And that should be 2 signs of multisystem involvement. And this and all, I'll skip all this, Dr. Satish explained. So about our patients, we had 10 patients with PCR positive who presented like fever, and according to the criteria, they had either a GI symptom or hypotensive shock. All of them had hypotensive shock. They had, some of them had GI symptoms, and one child had rash, and myocardial dysfunction was found in some of them. And we looked at the inflammatory markers. CRP was high in some procal. So usually we do CRP or either one of them, they're high, and D-dimer also high in all of them, or I will say most of the children. So they were all fitting into the criteria with the PCR being positive. And what about the treatment? As I told, it has been like that. It's as a respiratory support, mostly with high flow nasal cannula or non-invasive respiratory support. 6 children require ventilation. That includes all other severe and critical categorization. And as we said, those children who presented like a Kawasaki, we gave IVIG, which is 2 grams per kg, and anticoagulation. With initially, when the children are sick, we started with heparin, and that is unfractionated heparin. And when they are better, we changed to low molecular weight heparin. We continued till the time of discharge, and we didn't send them on any parameters, unless any aspirin or warfarin, unless Satish feels if they have a coronary heart disease or have a severe LV dysfunction, yes, otherwise no. So we had another child who presented like this, fitting into that, but PCR is negative. COVID-19, mother had COVID-19 in July, child was very sick, refractory hypotensive shock with myocardial dysfunction. He went on to ECMO and was there on with us ECMO for 10 days, and overall 20 days still the child was there. And by God's grace, child went home alive and came back for review as well. So we had similar patients, similar type of presentation with the spectrum of hypotensive shocks to moderate to refractory. 10 of these children, and all of them PCR was negative. We sent for the serology, and we found just this afternoon, I got the message, 7 of them are positive. Among the 10, which had a clinical suspicion, PCR was negative. History of contact, some of them had, some of them not. But they had other parameter criteria which fit into this WHO definition for MIS-C. And 7 out of 10, 7 children was serology positive. So the management, he discussed about everything. So probably while doing the discussion of the question answer session, we can talk about that. And so I'll just go to the summary. So what we know, severe COVID illness in children is significant, but far less than adults. But I would stress on the quality essential care of critically ill. That means whether they present with respiratory issues, you do appropriate respiratory support with escalation from low flow cannula, high flow devices, non-invasive ventilation, and invasive if necessary for ARDS strategy. Then if they are shocked, if they present with the shock, you always do not forget about sepsis. We need to follow the first hour management and the antibiotics as well. And as I told, our experience I have mentioned here. And MIS-C, as Dr. Satish said, it follows the epidemic curve pattern, and this needs to recognize. And in our children also, all children who are presenting with shock, we have to have a high index of suspicion. And there can be overlap of phenotype between MIS-C and Kawasaki. So we have to suspect early recognition, and a multidisciplinary team approach is necessary. Management, Dr. Satish has discussed IVIG plus steroids, but we have a coronary disease, you might think about it, and antibiotics also we have to give, as we don't know initially what this child may have. And do not miss sepsis as other common tropical diseases like dengue and scrub typhus. So they may also have cytokine storm. So you need to remember that. With this, I'll just finish and probably we can have a question answer session. Thank you. Thanks to all of the PICU team.
Thank you. Thanks to all the three speakers, Dr. Valsan, Satish, and Dr. Ebor. I think some of the questions Dr. Satish has actually answered on the chat box itself. I think as all of you have sort of heard, all three speakers actually touched upon MISC or PIMS-TS to a significant extent. So what it seems like, it's that, COVID is actually, it's a milder disease in children, but the only thing which is actually different about COVID in children is this MISC or PIMS-TS. With that, I'll stop and then I will take some questions. So the first question is from Dr. Pramita. Maybe Dr. Valsan or Dr. Ebor can take this. So can you comment on convalescent plasma recommendations in severe disease?
Convalescent plasma, actually, more and more evidence is coming out that it does not help. One of the recent studies is the ICMR one, which has just come out approximately a week ago. And so they are saying the issues with convalescent plasma is it depends on when you take it. So people are saying instead of convalescent, can we use hyperimmune globulin? Secondly, you are looking for neutralizing antibodies, and no one's really sure when you should be taking. And there are people who argue that you should be taking convalescent plasma in the first 14 days after the illness, because after that your antibodies come down. So on the whole, convalescent plasma seems to be not so effective.
Okay, thank you. The next question, in cases of mild disease, is there any need for investigations?
Absolutely not. In fact, yeah, I will say, so I think I just want to mention this protocol actually, Ebor, Satish, Winsely, myself, Dr. Anila Satin wrote, and actually what we said is if you have a URI, you don't do an investigation, you don't do an X-ray, you treat, especially as you treat any other mild infection. And because a lot of them recover, they go home.
Then next relates to BCG vaccination and its role in pediatric incidence reduction and benefit in immunity. Valsan,
so I'll take that. That's actually walks into what I was talking about, trained immunity. So that may be one of the reasons that children, BCG and other vaccinations, may be some of the reasons why children are relatively protected. However, you obviously need more than one vaccination, because if you take infants who have had less number of vaccines, they are actually not as well protected as older children, number one. Number two, ICMR has again recently just given BCG vaccine to a whole lot of 60-year-old and above people, and they looked to see what the immune responses were, and they found that these people mounted good immune responses to a BCG vaccine. Imagine at the age of 60, but whether it protects against SARS-CoV-2, they don't know. So BCG vaccination probably helps, but whether you would advise that to someone in the community, I probably wouldn't do till you get some more evidence.
So next question relates to severity of illness in a VSD child. Like I guess the question is, does COVID-19 cause severe illness if somebody has got VSD?
Yeah. So again, I'll answer that. Again, looking at people have actually looked at their own cardiac congenital heart disease registries, and they found that no, the congenital heart disease per se does not seem to be a risk factor. So not an increased risk of severe illness. Sorry.
So if I may just add to that, I think we've had a lot of children with coming with COVID and other comorbidities, and often the COVID-19 has not really been that severe just because they've had a comorbidity. I mean, that holds good for cardiac disease, even for some malignancies that sort of held good. Yeah.
In fact, there was one more. Ebor, sorry, you want to say something?
No. So I agree, because if they have an RSV bronchiolitis, they may do badly. when you have a congenital heart disease rather than a COVID-19 problem.
Yeah, but if you have a co-infection, then you do even worse. Someone actually asked a question about allergy. Are allergic children protected? And to be very frank, someone actually did the study in the US to look to see whether allergy/asthma children were sicker or had worse outcomes. And they said no. The one thing that's interesting is for asthma registries, because children are not going to school, not being exposed to pathogens, they're actually having less number of wheezy episodes. And if you think steroids work, they also another study looked to see inhaled corticosteroids do not really protect against COVID-19.
Okay. Thank you. So the next question relates to use of ACE2 receptor inhibitor drugs for hypertension, whether that will cause a more severe illness.
So Winsely, so that what we know from rheumatology, especially when they have lupus nephritis and all, we use a lot of enalapril. So what our American College of Rheumatology says that if somebody is already on the drug, ACE inhibitors, don't stop. But during this COVID pandemic, you don't start anybody new on ACE inhibitors. Try to avoid starting somebody new. But somebody is already on, don't stop. That's what our recommendation.
Okay.
The general recommendation in adults also, right, Anand? Yeah.
So the next question, I guess the next few questions relate to PIMS, TS, or MIS-C. So why are children more at risk of PIMS compared to adults? Satish, you want to take
that? So in children, we know that the immune system is so active, so active, because that's why the Kawasaki disease is more common. The T cell response, because it's all the T cell, overactive T cells, autoreactive T cells. So that's the reason why they have post-infectious PIMS TS more, because of the overactive immune system. And we have a lot of super antigen diseases. That's the main pathophysiology which is described in MIS-C.
Yeah, so the next question relates to, I think Satish mentioned that it is post-infectious. So if somebody is PCR negative, then, I mean, depending upon your isolation, rules in your own hospital, you may or may not actually isolate them.
Exactly.
Because in our own hospital, I mean, we'll isolate them till they are 3 weeks from the time of onset of illness. So, but if somebody has come with MIS-C, and you don't have a PCR which is positive, and if they're only antibody positive, you don't necessarily need to isolate them.
Exactly.
Yeah. So, then the next question is in relation to heparin and warfarin and MIS-C. Any indications?
I think that was covered. What we are doing here is we are actually giving it for those with an elevated D dimer, more than 500, or if they have any risk factors. That's your prophylactic anticoagulation. And therapeutic anticoagulation, the two indications I can think of are thromboembolism. There's just been recently a case report of a child with TB meningitis with cerebral venous thrombosis. And then the other absolute indication, which Satish will agree, is if you have a coronary artery abnormality. That would be an indication for prophylactic anticoagulation.
So the ACR guidelines is very clear. Somebody comes with severe shock, if the ejection fraction is less than 45%, and if they have coronary artery aneurysms, especially large coronary artery aneurysms, Z score more than 10. If somebody has got very well stable child in the ward where the D dimer is 1000, we are not going to give anticoagulation for them. Especially in ICU, Ebor agrees. In ICU, all the patients who are sick with shock, we are giving heparin. Correct, Ebor?
Yeah.
Yeah. But see, still, I don't know. That is, as we put the protocol, we are supposed to start for severe and critical. So for those children who are coming with shock and they are PCR positive and within the critical disease, yes, we do start unfractionated heparin for the first till they are out of shock, and they we put on the low molecular weight. Otherwise, when they are having evidence of myocardial dysfunction, yes, of course, all of them will be having. And all those who have this MIS-C presentation, we have this. But aspirin or warfarin, we are not sending them, as that is in your domain. Those who have probably coronary artery aneurysm, as you said, the Z-score about 10 or whatever, and those who have severe LV dysfunction, probably yes.
The D-dimer cut off.
None of the children went home on warfarin. Correct, Ebor? We didn't send anybody on warfarin.
No.
So when they go
Agreed.
home, we stop. Aspirin, if they have coronary artery, any involvement, Z-score more than 2, we start them on aspirin, follow them 6 weeks echo. If that echo is normal, you stop the aspirin, as like Kawasaki-like disease. Kawasaki disease, what is the protocol? Same protocol we follow here also.
I just want to mention about the D-dimer because we put that into the protocol, but the problem is we are actually, Ebor is looking to see what are the normal range of D-dimers, because we are actually getting children coming who have mild illness, not mild, moderate illness with an elevated D-dimer. Like Winsely said, we are not going to actually start them on anticoagulation if they are not sick.
Absolutely. We put above 500, actually take 200 to 400 normal or above 500. But in some centers, they follow more than 2,500. That's cut off. So actually, we don't know when to do that. And so we do more go by clinical standards, whether they are in the hypotension.
So the next question relates to, again, use of dexamethasone. So any contraindications to oral dexamethasone in someone who's got COVID symptoms and is on oxygen? So the question is, instead of them waiting for them to crash, should we give them oral dexamethasone if we are going to start them on oxygen?
It depends on how fast you are going, when you will get your PCR result, because most of the time you are going to get it in 24 hours. The risk of, you go on oxygen, obviously there is likely to be benefit, but the risk of having a secondary infection, I would probably wait for at least a 24-hour period rather than starting prophylactically everyone on oxygen.
Thank you. Okay, so the next question, can COVID-19 virus be isolated and examined, like during shedding? I'm not quite sure what that means, but...
Was that relating to genotype? That's the...
Maybe it is in relation to what Dr. Valsan mentioned, that you can actually find a PCR which is positive for 2 or 3 weeks or 4 weeks, but your infectivity is only 10 days. Dr. Valsan, do you want to elaborate on that?
Yeah, sure. So basically your PCR positivity can stay for a long time. So PCRs have a 40 cycle threshold cutoff for what is positive, what is negative. So you can be above the cutoff, and it's very difficult to do viral isolation. That's only done in a few centers. We don't do it here. However, in centers that have done it, they've actually looked to see whether they can get viable virus, beyond 10 days. And almost all the times they've said we can't get a viable virus. So the only reason for looking at virus isolation is to figure out period of infectivity, because your PCR positivity can go on for a long time. What does it mean is the question. So, we don't do it as a standard. That's all.
Okay. So, Satish, to you, how many days does the inflammation in MISC last?
So maximum of 7 to 10 days, Ebor. I don't think we have anybody more than 10 days, no, Ebor. Apart from that, if they have a cardiogenic shock and all, correct? Most of the patients we discharge within 10 days time.
Yeah.
But when they come with severe myocardial involvement, they do badly. So that may be prolonged. But actually, if you are giving this IVIG or whatever the treatment for IVIG, so there can be a response within 48 hours, right, Satish?
Yeah, correct. Correct.
Yes.
48 hours you should see the response.
Yeah.
And if not, we can add on steroids and tocilizumab if it is not responding.
Yes.
Yeah. So I've actually mentioned that in the last slide of my presentation. Your clinical response is 2 to 5 days with IVIG or steroids, and your markers, including your cardiac enzymes, outer limit is 15 days. So that's your longest period. A lot of people get discharged even if your enzymes are a little elevated, Because if you are clinically well, why would you keep? So which is why Satish is saying you still would do a repeat echo at 6 weeks. But with IVIG and steroids, the response is excellent. 1 week for clinical, 2 weeks for other markers.
There's a question, interesting question about has anyone seen patients presenting with COVID with features like a non-accidental injury, with bruise, seizures, and MRI showing bilateral subdural hemorrhages? So I'll ask Ebor to answer that.
I don't know.
Okay. So, I mean, I don't think we've seen it like that, but if I can say, we've actually had a few patients who actually had head injury and came in, and before neurosurgery, when they got tested for COVID, they were COVID positive. So just because they are COVID positive, I don't think you can necessarily say that, like, you know, their injury is non-accidental. It could be accidental or intentional. Then the next question is with regards to infection control. With the bronchiolitis season approaching, what's the take on use of nebulizations? Dr. Valsan.
Yeah, so you mean the issue is basically, I think what our respiratory person is doing is she's actually advising no nebulizations. She's saying you can give that through a spacer and a mask. You can give like how you would do a nebulizer. She's saying use your inhaler, use your spacer, use your mask, basically for just the reason that you don't want, you know, nebulized particles in your clinic or casualty or outpatients.
So the next question is a child with fever of 100 degrees Fahrenheit on first day. If it continues, should I recommend investigations? I think this was answered. Basically, if you have mild symptoms, there is no need for investigations. So the next question is on how long to give aspirin or heparin.
So aspirin, we told you aspirin as per the Kawasaki disease protocol. If they have Kawasaki-like illness, you start on aspirin. If they come exclusively with cardiogenic shock, gastrointestinal symptoms, no need to give aspirin. The aspirin recommendation is as per regular Kawasaki disease. You give initially 2 to 3 days till the fever settles, 30 to 50 milligrams. Then you make it to 3 to 5 milligrams. Apart from that, no need to give aspirin. And somebody has asked the question, if somebody is already on methylprednisolone, do you still need to give aspirin? That's a very good question. We had a very good evidence from Kawasaki literature. Whether you give aspirin or not, nothing is going to change. We have a very good Cochrane review. So if somebody is on methylprednisolone IVIG, if I don't give aspirin, no problem. It's not a big thing because aspirin is not going to change anything immediately. But the low dose aspirin will definitely help in preventing as an anti-platelet function. That has to be given. And next one question is role of tocilizumab. Okay, so tocilizumab is the third level of treatment. You start with IVIG, especially when they have Kawasaki-like illness, you start with IVIG, steroids. If both of them, still the patient continues to have fever, high raised inflammatory markers, you can give tocilizumab. In our cohort, whatever the patients we are admitted, we managed, we never used tocilizumab. Correct, Ebor? We never used tocilizumab in our group.
So I would say, yeah, it's like a cytokine form persistently. They are in the refractory shock. Maybe we have to consider that's what the tier 3 treatment probably. Yeah. But we are.
And in fact, in fact, even the Western literature, most of the series, very small percentages have actually received tocilizumab. You know, they've actually managed with IVIG, steroids. Tocilizumab has just about 10 to 15%, and that, you know, is in the early days. To be very frank, I think we've not even used antivirals.
Yeah, and remember that the tocilizumab last week, there is a study in NEGM has come. Tocilizumab does not do anything good in patients with COVID. Adult patients with COVID, tocilizumab doesn't have it is a negative study which is published in NEGM last week. It came with a very big hype. Even the tocilizumab drug is not available. It is gone into the black market a couple of months ago. Nowadays, it is going out of that market slowly.
The other thing I want to mention are the side effects. Again, there was another case published recently. Tocilizumab induced leukoencephalopathy. This is over and above the standard side effects, which is renal, hepatic. So it's not something that we are going to use lightly, and at least in children, I think we can manage without tocilizumab and antivirals. I mean, it's nice to have it in your protocol, but
what about
so far, so
repeat dose of methylprednisolone?
So methylprednisolone, the dose recommended is like you have to start, whenever you start with 10 to 30 mg per kg for 3 consecutive days. It's not one dose, followed by oral dose. We start with IVIG, then you give methylprednisolone, and you give it for 2 to 3 days like a pulse therapy, then followed by 2 milligram per kilogram for next 2 to 3 weeks. Somebody who is very sick.
Okay. And
only dexamethasone in our.
Yeah. So there is a question on that, dexamethasone versus prednisolone. Derek has asked. So the thing is, dexamethasone is taken over from the adult because in the recovery trial, dexamethasone was used because easy to give 6 milligrams. That's the adult dose. We have calculated the similar dose, Valsan, and we all calculated when we put the protocol, what is the equivalent dose in pediatrics, which is what he told, 0.15 milligram per kilogram OD dose. So methylprednisolone is very good, like rheumatologists especially, we treat always with prednisolone and methylprednisolone. Dexamethasone is taken from that remdesivir trial, the recovery trial. If you want to use dexamethasone, use it. If you want to use it methylprednisolone, you can use it. There is no big difference.
Okay. Then I think we'll take this as the final question. What do you mean by long COVID infection? I'll ask anybody to answer. I think it is to do with post-COVID syndrome, which happens in some people with who develop COVID. Yeah, anybody wants to answer that?
Or reinfection. I'm not sure whether that was one of the questions. I think I'll answer the reinfection question. Long COVID, I think the issue is if you're PCR positive for a long period of time, and that sometimes happens with children who are fecal PCR positive. So PCR positivity alone does not indicate that you actually have an infection unless there is a clinical component. Why some people are PCR positive, that is nasopharyngeal, no one really knows. Fecal, on the other hand, we know they shed for a long period of time. Reinfection is the other thing which people are talking about. The incidence of that is very little. It is usually due to a genotypically different virus. And I think that question was there, which is why it struck my mind. Antibodies and protection against reinfection. We don't know how long antibody persistence, at least neutralizing antibodies, persist. We know they go up to 3 to 5 months. There are studies that show they disappear faster. Convalescent plasma, one of the arguments is, you didn't take it when the antibodies were high enough. So theoretically speaking, you can still be reinfected, and which just means, until we have a vaccine that gives you adequate immunity and a good, neutralizing antibody response, I think hand washing, social distancing, and masks are the way to go.